Thank you. Thank you. Good morning, everyone. Welcome back. I'm going to introduce to you the next speaker. He's an expert in dermatology. He's somebody that I work with quite closely at the hospital at Westmead, and I'd like you all to please welcome Professor Pablo Fernandez-Peñas. Speaking about melanoma research, yes. He will clarify that a little bit more.
Hi, hello. Let's see if already my slides are up. That's perfect. So, thank you for inviting me to talk. It's always great to talk to the nurses that are helping in dermatology care. We need so much dermatology care in the communities. People, they don't get enough, and they're all the time knocking at our doors, and as much as we can help them, well, we will improve their lives. And one of the things that we can help is with melanoma. Melanoma, as you know, is a critical disease in Australia. Unfortunately, we're the capital of the world. Unfortunately, that's a thing that shouldn't happen. So at least one of the aims that we have in dermatology is try to reduce deaths from melanoma to zero. So let's see if we can go in that path. So, no, it's not moving from here. Not moving from here. Yeah, I'm using, it's not this device. Okay, they told me that it was the other device. Thank you. Yes. So the first thing is my conflicts of interest. I'm an academic dermatologist, so I love talking, so be careful with me. If you talk to me, I could be hours and hours talking, so everybody invite me to talk, I'm fine. Okay, so that's the list. All my talks, they're educational. I don't do any promotional. I just work for many companies because I want to teach as much dermatology to everybody. But also I work a lot with the industry to allow medications or facilitate medications to come to our patients. The other part that I do is many clinical trials, and you have all the list of different companies that we are running now trials at Westmead. And in most of them, I'm principal investigator, or I'm an associate investigator. So when they gave me, they said that I was going to talk about ASME, then the title came as Melanoma Research Update. I got confused, I didn't know exactly what to do. But it's true, I could talk about neoadjuvant therapy, it's very cool, or genomic analysis of therapy-resistant melanoma. That's another excellent topic, and prediction of response to immune therapies. There's a lot of things happening in melanoma if you're in that world, and it's gorgeous that we have all this. Then I thought, well, I'm not going to have time to go through all this. It's going to be very confusing. So I went to say maybe some of the things that we're doing at Westmead, and in that we could talk about in traditional treatments. We're in a number of clinical trials using plasmid and nanoparticles. It's very cool what we can do with patients that have metastases on the skin. But at the end, I thought that, yes, maybe the ASMID was the good topic to talk. And I'm going to talk about what we call precision medicine, so I call precision medicine, or non-invasive techniques that we can use for early diagnosis. And probably this is closer to what nurses could be doing in the melanoma space. So I'm not going to talk about melanoma getting worse and worse, you probably already know. So the incidence is still going up. We have a huge drop in mortality. And that's just because of immune therapies. It's not because we're better. It's not because our patients are protecting their skin. Still, when we do interviews, 50% of the subjects, they got a sunburn the year before. That's bad in this country, but it's still happening. People, they go out, they don't take care, they get sunburn. So that drop has been the amazing therapies. Remember, any of those biologics that we use is $120,000 per year per patient, and sometimes they need 2 or more. So it's extremely expensive. It's a way to treat this disease in the wrong way. The other part that it happens is that it's still 50% of the patients in 3 to 4 years, they're going to relapse or they're going to die from the disease. Okay, so it's good. There's some cures, and the word cure start to come in melanoma. It's amazing, but it still is not the way to go. We need to stop the disease before. So one of the things that we can do is detect who's at risk, and that's something that you can detect who is at risk, and you have all these leads, personal history, family history, the age, the older that we get, so I'm getting there, more chances of getting a melanoma, prior removal of moles, UV exposure, immune suppression, some genetic susceptibility, and we look at the skin and nevus count and a typical nevi, all these, like coloring your hair, like coloring your skin, all these factors, they need to be taken into account at the time to detect who is at risk. But another thing that you can do is to go to the Melanoma Institute of Australia, and they have this tool. So if you don't know about the tool, you can just recommend to all your patients and all the people that you interact. You go there, you put your details, and this is Australian data. Okay, we cannot say that it's applicable to people outside Australia because it was done with research done here in Australia, and it defines, and that's my risk. Okay, I have a 4% risk on my lifetime of getting melanoma, and because it was done last year, it says that my age is 57, but now I'm 58. Okay, so, but that's not enough. That's a risk, what is going to happen. But which one of those moles is the malignant mole? Now, you have seen this. You're seeing patients with the skin, you're seeing patients with moles, which one it is. And you can look closely, and there are too many of these. Well, at the end, in this case, was the one that is in the red square. But people could argue that could be any of them, the one that is the malignant one. So people, they cut out things, and you may have suffered. You may have patients that you're working with, that they have suffered things like this. This person got 18 excisions. All of them were benign, just because the clinician was not sure. And that happens too often. In fact, the number needed to biopsy goes from 2.2 to 287. 287, that's a recent paper that is here, the paper, okay. Usually, if we get all the doctors, in GP world would be 30 to 1, all the doctors together would be around 15 to 1, dermatologists 7 to 1, still there's a lot of ineffective surgery. If you come to our high-risk melanoma clinic at Westmead Hospital, still we need to cut out 3 things to get 1 melanoma. So there's a lot of activity that could be dedicated better instead of just getting and cutting out things on all our patients. At Westmead, we're so good because we do this. We used to do this, very time-consuming. And some of you have done 2D photography, whole body photography, different positions. You have this stance all the time and moving one way or the other. Repeating again the same thing is very complicated. We do the dermoscopy, as you see here. We get close to the lesions to try to identify signs or changes, not sequential digital dermoscopy. Very good, but it's complicated. In any case, we cut them out. And then when we cut out, we send to the pathologist. And maybe this is a surprise for you, but pathologists are human beings. And the same as you struggle seeing a mole and seeing if this mole is good or bad, pathologists, they struggle the same. They don't know if what they're seeing is or not a melanoma. So not that long ago, this paper is 2017, a group of pathologists, they got together and they classify a good number of lesions as benign, potentially malignant. This is a melanoma in situ, probably. This is an early invasive melanoma, and this for sure, this is an invasive melanoma. Nobody can doubt. So they got a good number of slides with all this, and then they get it to some pathologists. This was done in the US, okay, so it's not your local pathologist, but you can imagine that they gave it this to the local pathologist. And this is the agreement of the local pathologist with what a group of good, very academic and driven and people that know thought about the things. So yes, most of the people in the community, they agree that a benign is a benign. But in the potentially malignant, only 24 agree on that. In fact, most of them, they thought it was benign. When we go to melanoma in situ, only 40% of the study pathologists, they thought. And when you go to even early melanoma, only 42% of the pathologists, they thought that it was an early melanoma. In fact, 7% of the pathologists, they thought that it's a completely benign lesion. So there are problems also in pathology, and that's one of the reasons that they say that in Australia we have an epidemic of melanoma in situ. Just because it's so easy to say that something looks ugly is a melanoma in situ. So that builds up even more in the drama of how many melanomas we have. And it's very difficult because I can understand a pathologist just looking at a slide has to decide this patient they need more surgery or doesn't need anything. And there's no context. It's just a slide. And it's a human being like you looking at different cells. Okay, and I'm sorry that I haven't brought any histology photo. I should have brought one. You're going to see one later. So we want to go into what is called precision medicine, and you probably know this is the right diagnosis for the to get the right treatment and obtain the right outcome. And we need to get this for each patient, and we want to bring this to the melanoma world. So we were bold, and we presented a huge grant to reconceive how we do melanoma diagnosis and screening. And that's the Australian Cancer Research Foundation, Australian Centre of Excellence in Melanoma Imaging and Diagnosis. Too long, but it's ACRF, that's the funding body, and ASMIT, that we are the group. 3 universities, the University of Queensland, Monash University, and the University of Sydney, that is where I'm working. And we went to ACRF, and they have these amazing grants you can apply. So if you've got a good idea, just get a good consortium and you can apply. And from every 3 years, they give $10 million, so close to $10 million to something that could change the life of Australians. It's a good endeavor. So we say we want to change how we do in early melanoma. And for that, what we want to do is we are going to create new artificial intelligence that is going to help us to diagnose things. We're going to take photos of everything. We're going to try to evaluate how much money we're saving because we have all this new technology. We're going to implement it and show that it's cost effective. And we're going to integrate this in a telehealth network, so someone that is in Port Macquarie or in Wagga, because I will tell you about that later, they can take their photos, and even there's no dermatologist, we can give an advice from another place. So a dermatologist from Sydney could check, and regardless what you are in the state, or in this case in the country. So we are going to integrate, we are going to get all this. So we presented to $10 million. We want to have 15 3D photography systems in Australia, all connected. And we went to ACRF, and in that time, we got it. We got it. So we got $10 million infrastructure grant to create the world's largest, more comprehensive skin imaging database. And from that, developed tons of different tools that will help us with the early diagnosis of melanoma. This is the device. That's the one that we have at Westmead. So if you go to Westmead, it's not too far. It's only half an hour, or a little bit more driving. Probably on Sunday will be easier. Okay, you can go and see the machine. And we take one photo, and the computer build this 3D version. And you're going to see how close it gets to the skin, that you can even see the hair follicles. It's quite amazing seeing here. It's quite impressive seeing here. But when you see it in real life, it's even more impressive. And you can talk to Vivian here and can tell you everything, because she's one of our melanographers managing the device and taking photos. Already we have taken 300 subjects in Westmead. So this is the team. Tori Marr from Victoria, in New South Wales, and the boss, and you know him really well, Peter Sawyer from Queensland, that is talking all the time in every single conference in the world about this. But we are just the heads of a huge group of people behind to try to bring new technologies and new way of diagnostic. So 5 devices for Queensland, 5 devices for New South Wales, 5 devices for Victoria. All they're going to be inside their e-health or health networks inside in the States. And then a copy, the identified copy, is going to come in a huge repository under their universities for all the research that we are going to do. We got a lot of in-kind support. So most of my, I dedicate to this project at least one day a week just to get things done and get things. So the University of Sydney is paying my salary one day a week just to dedicate to this. So there's a lot of in-kind support from the universities. There's some cash support, and we have project managers that are helping this, just again from the universities. So this is an infrastructure grant, so we need to build everything else around. We need to pay people, we need to do things. So it's complicated, but we got a lot of people involved, and you can see names of different universities, LHDs, and health departments that are participating in the project. And what we've done is, you have heard about the genome, the proteome. Well, we're going to get the imaginome. We're going to get all the possible presentations of skin lesions on the skin. And the current software can do this, can detect quite a good number of lesions and can classify and give you size and all this. We know that it's not perfect. We want to get better. But it's not only just classifying that. What we're more excited is about this. You go one day, You put your position, you get your photo, and 6 months later, 1 year later, whatever, you go, and then yes, the melanographer will tell you, move your arm one to the other, take another photo, and the photo is so similar that you can compare things. And that's where the trick is you can compare. Because it may be that you have a melanoma, let's say, but if the melanoma is not moving, it's not going to kill you. We can avoid all these melanomas in situ because, in fact, someone is now discussing that we need to remove the diagnosis. You know, it's like the prostate and in other breast cancer, they're discussing that we find so small things that at the end everybody gets so much surgery, so much intervention that is not needed because it's not going to ever kill you. So in the skin, it's very easy. You take a photo, 6 months later you take the photo, not moving, that's okay. That lesion moves, you cut it out. And that's the trick. That will be the trick to get a screening very effective for most of the population. But as you can read in that thing, well, I'll make a translation for those of you that you don't know about Tolkien and their language. One ring cannot rule them all. That was in the lot of the rings, that one ring could do everything. We know that imaging is not going to be. In biology, we need more than one omics. This imaginomics has never put in the thing, so we are one of the first group to add it, but of course we're going to do more. We're going to collect clinical data, skin type, skin color, hair color, eye color. This is all funded. We got a NHMRC clinical trials grant, and that pays for data collection. So now we can pay 0.4 of an FTE of a nurse in the places. We want to pay the full time, but we can't, so we are still counting on the LHDs and the facilities to support the project. We're doing some polygenomic risk, so there are patients that have some mutation, multiple moles, but there are people with no moles, but still they have mutations and they have 2 melanomas. So we need to accommodate for people with multiple moles, but also with people with very few, and understand the risk. This is partially funded. We got money to swap the oral mucosa for a number of patients, but we don't have still money to do all the genomic studies. And it's only a small group of all the patients that are going to get this test done. This is the histology. So we're going to have curated histology. So every biopsy, every lesion that is removed, it will be collected, a slide will be scanned, and that will be sent to a number of pathologists that have decided to participate. And this is, the scanning is funded, the scanning is funded, the time of the pathologist is not, so we still depend on in-kind support. But that's the thing, you need pathologists, they need to decide if you see something like this, if this is a melanoma invasive or a melanoma in situ. And this is a human being deciding if those cells here, they're already melanoma cells or not, they're lymphocytes and they're benign. So it's very complicated for the pathologists. A scarless biopsy, I will talk about this a little bit later, so I'm going to skip this one, but that's something that is partially funded. And how we're doing? Well, the project commenced just before COVID, and we got really badly hit, and has been just a nightmare to try to build the things through COVID. So we're now taking finally off. As you see, of the 15 sites, we only have 8 that are collecting. You see the number of subjects that are in every place. Here is Westmead. And of the 15,000 target, we are at 24%. But we're going there. And we're adding more sites in New South Wales. For those that you're here, we want to put one in Wagga, another is going to go to Port Macquarie, and probably we're going to get one in Orange if we're lucky. Let's see if we can get the other 3. One is in the Melanoma Institute of Australia that you see here, and the other is in Westmead. So 15,000 subjects with all type of risks, so anybody's invited. Doesn't matter that you don't have any risk. We want from type 1 to type 6 skin. We don't care because we need to get all the range of skins, all the range of moles to be able to develop an AI that could help. Because many of the systems that you get at these apps, they're being trained in a small cohort, just, very rich, 50% of the lesions, they're melanoma. Yes, then apps, they work really well. But when the melanoma is very infrequent, then they don't work that well. So we want Australian population, as more varied, all ethnicities, doesn't matter, to collect and create the largest multi-omics database. That's the main thing. And what we will do with all this, well, yes, you heard about artificial intelligence, we're all talking about it. We will create some systems that will help us at least to rule out some things. What I'm saying is we want to go to a national screening program for melanoma. What's the expensive of this? That you need a human someone that is trained in looking at the skin, looking at the whole body. So that takes time. In fact, if we were to say, yes, melanoma is such a disaster, let's get every Australian to see a doctor. There's not enough doctors during the whole year to see all the patients, all the population in Australia. We can't. All the doctors, not just dermatologists, all the doctors. It's impossible. So that's kind of work, unless you do this. You go to a machine, you go to your next supermarket, you swipe your Medicare card, you step in, you remove your clothes, of course. We cannot see through clothes at this stage. You take the photo, you get out, and then minutes later, you get a message that says your skin is the same as 6 months ago, you're good to go, or this lesion in that place has changed, go and see your doctor. That will be amazing, and that's one of the dreams that we have in ASMIT, with many others, but that's one of those that could work. Okay, I'm not saying that it's going to work, but it's one of the aims if things they go well. So what is this thing about the scarless biopsy? So this is another research. This is happening exclusively in Westmead with my team. And it's this thing. We use tape stripping that some of you, if you're involved in clinical trials or you've been doing some research, you may have heard about it, that you got a tape and then you put the tape on top of the skin. As you remember, the epidermis, the top of the epidermis is called the stratum corneum. This traps some of the stratum corneum, you lift it, and then you can analyze. And you analyze what is the content of that part of the epidermis. And yes, when you see something funny, you could go directly to cut it out, and you have your pathology or whatever. Or what we propose is that we put some tapes, you send the tapes to a lab. Those proteins that are inside those tapes that are collecting from the surface of the skin can be analyzed. And what we get, well, we got the tapes, as you see here. We extract the proteins. We do a whole process of the thing. We analyze in a machine. And then we got this. And this is early data. Okay, we haven't published yet. But we have melanoma here, melanoma, minimally invasive melanoma. And 13 samples, they go into one of the, in the red thing. And most of the benign lesions that go to the other. Still, there's overlaps, and there's these intermediate lesions that some pathologists would diagnose as dysplastic or in situ. We could say, look, these dysplastic and this in situ, they're the ones that have the same protein component as melanoma, probably are the ones that you need to remove. But these dysplastics and this in situ, they perfectly match with your normal benign nevi, so probably just observe, there's no need to do. Okay, so we want to add this. So at the end, and this is with machine learning, we use it with machine learning, and we get an accuracy over 80% in how we can predict just taking the surface of the skin. 80%. So our proteomic analysis better than most GPs at this stage to diagnose melanoma. So it's quite good, but still we need to validate and do a few more things before we can go to other places or go to industry. So what will be the thing? You will have your imaging. You go, you get your imaging. If it's all good, yep, you go home, nothing to do. If something is really bad in the imaging, we are gonna know. You could get your surgery. But if things are, I don't know what it is, then you get your scarless biopsy. And the scarless biopsy will tell you, yep, this is completely good, no problem. Oh no, look, this is something that needs to be cut out because it already is, or maybe because it has the proteomic, the amount of proteins in the cell that look like it's going to be a melanoma. And if it's still unsure, then you go back. And 3 months later, 6 months later, you take another photo and the process is done. No surgery, no scars. That would be so beautiful. Okay, so that's the future. If you want to see more future about scarless and all these diagnostic tools and more things about dermatology research, you can come to Westmead. We're going to organize the next meeting of the Australasian Society of Dermatology Research at Westmead Hospital. You will be invited also to see our new space. It's probably the most beautiful and best department of dermatology in Australia, not because it's mine, it's because it is. I've seen people coming to do the accreditation from the college and they can't believe the new space because it's really gorgeous. And I want every hospital, public hospital in Australia to have a design and a structure similar to what we have at Westmead. Then yes, we need to bring dermatologists and we need to bring nurses and we need to fight with the management and all these things. But you can come to the meeting, you can see the department, you will learn more things. So thank you lots for inviting me. I'm happy to take questions. Say it again? So the machine, I don't know what the commercial value is. Okay, I haven't asked Canfield. You can go and talk to them. They're here. I don't know how much really costs if you want to buy. I think that is less than $500,000, more than 300,000. But I don't know. Okay, I'm not a commercial person. Like in many things, I don't get involved in that. But I know that it's no more at this stage more than $500,000. So compared to many other devices that people they buy, in particular in hospitals, like a CT scan, a PET scan, or whatever, it's way, way cheaper. So at this stage, ASMID is free because it's a research project. We are not diagnosing, we're not doing any of those, we're just taking photos. Of course, if we see something, we inform the referring doctor. So if you were to come, for make the case, you will have a letter from your GP or your dermatologist or someone that wants to send you to us. You will be included in the program. You will get the photos. If we see something, we will say, oh, this lesion here and this lesion here, please take good look of those. We decide for their doctors at this stage to decide what they want to do. It's all for free.
Could I just ask, if it's okay, with the scan, can it see through tattoos?
No. So what we do is surface photography. So the problem with tattoos or clothes is that it mixes with the thing. We hope that the AI could help us. For example, worse than tattoos. I'm just the opposite of the cosmetic thing. I'm covered with hair all over my body. So if you take a photo of my body, it's difficult to see my moles because there's a lot of hair. But we already have got a software that can remove hair and predict what is underneath. Okay, so we can remove, if you've got a very well-organized tattoo, it's not too difficult for image analysis to predict how much of the color is similar to the sides of the lesion, and then, in a way, subtract that from the lesion and get what is the lesion by itself. But no, the scan cannot, it's just surface photography. It's like your camera, but very cool. In fact, in the device, I haven't said, in the device there are 92 DSLRs, 92, okay? Not just the normal iPhone or any smartphone camera, it's the DSLR, the same as you've got the professional DSLRs that people, they do in journalism and all this. So there are 92 of these looking at a person, one flash, and then at this stage, the computer that we have takes 20 minutes to build the avatar. We're waiting for a new version, and we will probably get it because it gets reduced to, I think, 12 minutes. So that will give us a little bit more time with the patient. So we prefer to be with the patient than waiting for a computer. But we know that this is going to get better. It's the only way, most of these things, that will get better. Any other question? Okay, thank you.
Thank you very much.
Thank you.
Really good. I will introduce our next speaker. Our next speaker is Associate Professor Peter Wong. He's the head of rheumatology at Westmead Hospital. And we invited Dr. Wong because it's very important to see the links between different specialties with rheumatology and dermatology, with psoriasis and psoriatic arthritis. So he's an expert in his field, and I'm looking forward to working closely with him this year. Please welcome Associate Professor Peter Wong.
Dermatology USB. That one.
Which one? That one?
Yeah. Perfect. Lovely. Excellent.
I'll switch that over.
Thanks. Thanks so much, Vivian, and the ADNA for inviting me along on this beautiful Sunday morning. I'm from Westmead. I'm very lucky that I get to work with such a dynamic department of dermatology, and I think the reason I'm here is because pre-COVID, Annika Smith is one of the dermatologists at Westmead that I work with, and I set up a combined psoriasis, psoriatic arthritis clinic. And unfortunately then COVID started, and so we had to not do much for a while, but we've since resurrected it, and I'm hoping to to do a lot more with the dermatology department. So I thought I would talk about what dermatology nurses should know about psoriatic arthritis, and obviously we'll talk a little bit about multidisciplinary things. But I'm so pleased there are so many more of you than there are rheumatology nurses. I would love there to be more rheumatology nurses, but there are so many of you, and I'm so pleased. We need more like you in my specialty. So this is where I'm going to go over the next 25 minutes or so. I'm going to give a brief overview about pathogenesis of inflammatory arthritis, treatments, because it really has changed dramatically. And I'm going to talk about two things which I think you guys really should be very involved in, which we don't often think about, and that's health literacy and medication adherence. But let's start with the more normal stuff first. So you know this better than I do. You know, psoriasis, cruddy nails, which I look for all the time, and scalp psoriasis. So you've seen lots of that. What you may not have seen much of, but I'm sure you will after this talk, hopefully, is psoriatic arthritis. So this is what I spent a lot of my life seeing. So in the top left-hand picture, look at the red arrows, please. He's got a swollen right fourth toe. And someone had thought, oh, he's probably dropped something on it, or he's got a fracture or whatever. But in fact, there was no history of trauma. And so this guy has a psoriatic dactylitis. So dactylitis is basically a swollen, inflamed, puffy toe. Looks like you just dropped a can of something on it, but it's not atraumatic. And that's one of the manifestations that I see a lot of in psoriatic arthritis. The X-rays that you'll see, the top right-hand one, that is a fifth finger, and you can see the red arrows highlighting sort of quite bad joint damage. And that is not osteoarthritis, that is actually psoriatic arthritis. These are all of my patients. The bottom left is a coronal section, so looking at you from the front, and that is someone's sacroiliac joints. So on the right side and the left side, again highlighted by my red arrows, there are these little holes. And so they are psoriatic arthritis erosions that are damaging this person's sacroiliac joints. And again, this is someone else's different right fifth finger, which is slowly being eroded away on the bottom right-hand side by psoriatic arthritis. Psoriatic arthritis can do anything. So it's hard to kind of communicate the what it feels like on a plain still picture. But the bottom left, when I first saw him, I thought, oh gosh, you know, he's probably got rheumatoid arthritis. He's got symmetrical, swollen, puffy, small hand joints. In fact, it's actually a psoriatic arthritis. It can look just like rheumatoid arthritis. And this is someone that initially we thought, oh, the middle picture, gosh, you know, he's probably got osteoarthritis, affects the distal interphalangeal joints, so those little things at the end. But in fact, note the cruddy nails. Very scientific term, sorry, Pablo. You know, psoriasis, psoriatic arthritis, the nail onycholysis, you know, this person's got psoriatic arthritis. This person I was seeing for quite a while with funny ankle pain, and you can see that this is a lateral view of the subtalar joint. That's the joint below the ankle, and it's really irregular. If you have a subtalar joint like that, it's going to hurt. And this is psoriatic arthritis as well. And I actually worry more about psoriatic arthritis because it tends to cause more erosions and more joint damage than standard old rheumatoid arthritis. Most of the really bad erosive arthritides I see are probably psoriatic. So it's surprisingly common. It affects 1 to 2% of the general population. The prevalence of psoriatic arthritis in psoriasis patients, look, the figures are between 6 and 40%. I tell people if you have psoriasis, you've probably got about a 1 in 5 or a 1 in 4 chance of getting psoriatic arthritis. So there's a reasonable chance you'll end up seeing someone like me. And usually you get the skin symptoms first, so you get the psoriasis, and then you come and see people like me. But sometimes it's really tricky that you might get the skin and the joints at the same time. And it's really tricky sometimes when they come in and they've got the arthritis, you're wondering what is causing this. Their blood tests are normal, they have no psoriasis, and then they get the psoriasis 2 or 3 or 4 or 5 years later. And that's a really tricky diagnosis for us to make. But you've got to look hard. One of my colleagues here in Sydney, he entitled one of his topics, one of his talks, I remember once, Psoriasis and Psoriatic Arthritis Beyond the Natal Cleft. So he had to look awfully hard to find the psoriasis. So it can be really tricky. It can cause anything, so it can cause a oligoarthritis, means less than 4 joints. It can cause a polyarthritis, so more than 5 joints. Often affects the finger and the spine, and it can be really nastily erosive. But it's definitely correlated with a poor quality of life, lots of healthcare utilisation, and it's generally a bad thing. And doing it, detecting it early and treating it is a really good thing. And I think that's where you guys really, please think about psoriatic arthritis in any one of your patients with psoriasis. So a couple of slides, a little bit painful on a Sunday morning, but let me just take this through you slowly. So this is what happens with inflammatory arthritis. So you have an antigen-presenting cell that takes an antigen, and that's usually a bit of your joint. What it does is it then presents it to your immune system, so your T cells and your B cells, and then it spits out all this sort of stuff. And that's on the right-hand side where you've got all these very irritant chemicals like TNF, IL-6, IL-1, etc. And that's what causes the manifestations of inflammatory arthritis, the painful, the swollen, the stiff joints that the patients complain of. Now, the reason I'm showing you that is because that's probably taken 50 years for people to work out what the pathogenesis is. And this next slide is actually a very encouraging slide, I think, because it's all the steps that I showed you in the previous slide. But the red stuff are the drugs that we have to use. So we can effectively block almost all of those spots and those processes that result in inflammatory arthritis. And these are all drugs which are currently in standard use on that magic PBS form, which goes for 4 pages, which you know and love. But we can block almost all of those processes, which I think is absolutely amazing. And that has probably happened in my professional life, which is I think I'm really lucky to be practicing this time, I think. So what is really interesting, the bottom right hand where it says CAR T-cell therapy in red, that is really very new. And that is interesting because until now, we can block all these pro-inflammatory chemicals, but this paper came out last year actually from a rheumatologist, a really smart rheumatologist in Germany. But what they're doing now is they can actually take T cells from someone, isolate them, stick something into it, and then get that T cell to target a particular thing in the body, and it chews it up. So it's very much the epitome of targeted therapy. And this is 5 patients that had awful lupus, just really, really bad lupus, who are probably now cured. Well, he claims they're now cured. At least 2 or 3 of them are cured by this condition, so drug-free remission by CAR T-cell therapy. And so that will now move on to scleroderma, I think is the next disease that he's going to try, rheumatoid arthritis. So this is really revolutionary stuff. So the treatments are really revolutionized this. This is one of my patients. I put him on a biologic to fix his, he actually had rheumatoid arthritis, and then he sent me about 4 months later this picture. This was his new hobby because he felt so good. You know, one of my colleagues at Westmead says you should never fly in anything that you can't push a drinks trolley down the middle. And I think that's pretty good advice. So just terminology. So when a rheumatologist talks about medications, we talk about conventional synthetic disease-modifying anti-rheumatic drugs. It's a real mouthful, CSDMARDs. And that's stuff like methotrexate or cilazaparin. I mean, I know you guys use methotrexate. So that's what we would call a conventional synthetic DMARD. That's the old stuff, still works really well, we still use it. The next thing we use are biologic disease-modifying agents. Things like, I know you use secukinumab, which is Cosentyx, the IL-17 blocker. I know you use adalimumab, which is Humira and a million biosimilars. So they're biologics, and the reason they're called that is because they are grown in live cells. And then the next wave, which I know you guys are about to get, or you may have already got it, I'm not sure, but you're going to get it soon, and these are called targeted synthetic DMARDs for me, but you're going to be using them for psoriasis. And these are what we call small molecule inhibitors. So the biologics, as you know, are injections. The next wave is going to be small tablets. And they have revolutionized my world because you don't have to carry around the ice pack and the ice block when you travel, keep them in the fridge. These are just tablets. And so these are kind of like oral biologics, if you like. So they will come to your field if they haven't already come to already. Now this is a really sort of confusing slide. Don't get too bogged down in the bottom details. In fact, I realise I've got a pointer here. No, I don't. So that's okay. Okay, so all I want to concentrate on is the top line where it says peripheral arthritis, axial disease, enthesitis, dactylitis, psoriasis, nail disease, IBD, and uveitis. And those are the manifestations of psoriatic arthritis. So it causes a peripheral arthritis, which you've seen. I've shown you the beautiful pictures. It can affect your spine. So the classic one is just the young guy who's 25 or 30 who's had back pain for 10 years. And it's always the pillow. It's always, I lifted something at work, but it's actually his psoriatic arthritis, right? Axial disease is really common in psoriatic arthritis. Enthesitis, so the enthesis is where your tendon sticks to bone. So for example, Achilles tendon, lateral epicondyle on your elbow, and so enthesitis is classic for psoriatic arthritis. The dactylitis is the swollen finger or toe where people think you've dropped something on it, but you actually haven't. That's a classic. Obviously, the psoriasis that you're better at picking than I am. The nail disease, the inflammatory bowel disease. So probably, 1 in 5 people with psoriasis, psoriatic arthritis have inflammatory bowel disease. They just don't know about it. And so, I'm always curious about, bleeding from the back passage, abdominal pain, all that sort of stuff. Uveitis, so inflammatory eye disease can be a manifestation of it. So these things all cluster. So it's a much more complicated disease, a much more multifaceted disease than, say, rheumatoid arthritis. So please think about all those things that I've mentioned. And the reason it's worth thinking about is because it's so treatable. So these biologics which I have here, you use a lot of them, as do I, and these have really revolutionised my world and hopefully yours. So TNFs, as you know, have been around, 25 years now. You use a lot of adalimumab or Humira, as do I. Etanercept or Enbrel, you probably use a bit less, and infliximab, which is the TNF inhibitor. They all work really well. There's a little table that I've put down there. TNFs work pretty well for the skin, pretty well, not as good as some of your newer drugs, but they work pretty well. They work really well for the joints, and they work really well for the gut. So I must say, I tend to use a lot more TNFs than you guys do still because it works for the joints and the gut. The IL-17s, you have 2 to choose with, and the secukinumab or Cosentyx and the ixekizumab or Taltz. They work brilliantly for the skin, as you know, and I'm embarrassed because when I go to your talks, you guys talk about PASI 90s or PASI 100s, which means, 90% clearance of skin or 100% clearance of skin. We're still at what we call the ACR 50 stage, which is about a 50% reduction in swollen, painful, tender joints. So we're not at ACR 90s or ACR 100s. We don't talk about that. So you guys are way ahead of us in terms of treating the skin. The IL-17s are pretty good. They work really well for the skin, as you know. They work pretty well for the joints. That's probably why I don't quite use as much of it as you guys do. They don't do anything for the gut. They don't work for inflammatory bowel disease. In fact, there's data suggesting they might even worsen it. And so that's why I'm a little bit cautious with an IL-17 in this context, although you guys use it for skin and it's great for the skin. Something that's probably changing that has reached my world before yours is the JAK inhibitors. So JAKs are the Janus kinases. They are intracellular enzymes. So they are located in the cell. I've had 3 oral JAKs to play with for about 2 years now. They work really well. No 4 degrees Celsius, no ice packs, just pop a pill. They work really well. There has been a signal lately for increased risk of cardiovascular disease and potentially increased risk of malignancy. So there is a black box warning about CVS and cancer, something to be aware of, but they are very convenient. They work pretty well for the skin, pretty well for the joints, and pretty well for the gut. The gut doctors are about to get that listed for Crohn's and ulcerative colitis. So again, they work well for the 3 different domains, but again, just that signal about vascular disease and cancer. So IL-12s and 23s, ustekinumab or Stelara that you guys use. Look, I don't use a vast amount of it because I don't think it's that good for joints, but certainly it's very safe. You know, I have no problems with using it. And you guys have had guselkumab for longer than I have in terms of the IL-23s. You have more experience with that. I'm still getting a feel for exactly what it's like for joints, but I know you guys like it for skin. So I think the particular issues that Annika Smith and I struggle with our PSA, PSO patients are they're usually overweight, and that is a problem because we now know that adipose tissue doesn't just add weight. It actually produces pro-inflammatory chemicals like TNF, IL-6, IL-1, all the things that I try and block. So now when I say to patients, look, I tell them, I need you to lose weight because it's not just the weight. It's actually, it makes your disease harder to control and you won't get as good an outcome unless you try and lose some weight. So we talk about that and we talk about strategies to help them lose weight, etc. So that's an important discussion, often a bit awkward, but an important discussion which I need to have with my patients. Leads on to fatty liver. So fatty liver, again, we used to think it was a bad thing, but not too bad a thing, but it's actually not great because when I put someone on methotrexate, for example, or cilazapirin, I do liver function tests to monitor, and then if they've got fatty liver, the LFTs are often a bit off anyway, so it's strictly to monitor. Plus also, alcoholic or non-alcoholic fatty liver can actually cause cirrhosis. So it's something to be aware about. If they lose weight, the fatty liver will improve. Cardiovascular disease, we used to think if you had inflammatory arthritis, people were dying more. And we used to think, oh, it's the bad rheumatologist that was immunosuppressing you, you were dropping dead from cancer or infection. In fact, that's not true. It's actually the heart attacks and stroke, not the bad rheumatologist. And we now know that a systemic inflammatory process like psoriasis, psoriatic arthritis, rheumatoid arthritis increases your risk of vascular disease, so heart attacks and strokes. So that's really important. If you treat effectively, you will lower the risk of vascular disease. And also something which I often forget, but certainly the dermatologists have taught me a lot about that, is the poor body image because of the psoriasis. And that's something I often forget, the depression, the anxiety, but it's worse than what someone with rheumatoid arthritis that doesn't have the body image issues has. So something to think about. And also psoriasis often associated with gout. So painful swollen joint in the setting of psoriasis, could be psoriatic arthritis, could be gout. The only way to tell is to pop a needle in and look for crystals. So this is a tricky group of patients to deal with because they're really complicated. So side effects of immunosuppression, so obviously I do that, as do you guys. Infections are a problem, but also skin cancers, and I won't dwell on that because Pablo's done a beautiful talk about it. I must say, we used to worry a lot more about immunosuppression and increased risk of cancer with it. Unfortunately, these days, so many people have cancers. 1 in 10 Australian women get breast cancer. So we're inevitably immunosuppressing someone that's got a history of cancer. We're a bit less worried about it these days. You're a bit more comfortable immunosuppressing in the setting of cancer these days because these drugs have been around a long time, unless they're on a JAK inhibitor. So that one is something which we do need to be worried about. So this is probably the commonest referral I get from the dermatologist. I've got a 35-year-old, it's usually a man, with psoriasis, whose psoriasis is brilliant on your fancy new biologics, but they're getting joint pain, joint stiffness, and they're just a bit achy, a bit stiff, a bit sore. So the things that I want to know as a rheumatologist, I want to know which joints are involved. I want to know how functionally impaired they are. Can they carry their baby? Can they work? Can they use a mouse? Can they drive a car? I want to know how long the morning stiffness lasts for, because the longer the morning stiffness, the more active the disease is. I want to know about their comorbidities, their weight. I want to know about their vascular history because it impacts what drugs I use. And obviously, I want to know if they want to fall pregnant because it determines the drugs that I then use to suppress them. And so you will find that usually if you deal with your rheumatologist, by the time they come to me, their psoriasis is usually great because they're on an IL-17 or something like that. And so I usually just add in a bit of methotrexate, old drug, works brilliantly, or some other conventional synthetic DMARD. And that's usually enough. I try not to switch them from your wonderful biologic because the biologics I use are good for joints, but they're not necessarily as good for the skin as the ones that you choose. And this is why having an MDT with a dermatologist is fantastic. I mean, you're very familiar with the intricacies of PBS and which way to jump, PSA, PSO. So it just saves the patient the having to come back again and again to see us or the dermatologist. If we just make that decision early on, and then you jump on the PSA or the PSO pathway, and you just go along that pathway. I really encourage you to work closely with the rheumatologists in your institutions. We're all pretty nice, we don't bite, so I really encourage you to liaise with them closely. So in the last few minutes, I guess I got into this a long time ago, just thinking about, because I used to practice in Coffs Harbour, we suspected our patients didn't read really well. So we did the study some time ago now, trying to work out their level of literacy, which you and I take for granted because you go to conferences, you read conference programs, you read scientific literature, but to a lot of our patients, that's not a normal thing to do. So when we actually drilled into this, we gave them some questions, like, for example, question 1. Tramadol is a strong painkiller. These are 50 milligram tablets. How many tablets would you need to make a dose of 150 milligrams? It's 3, right? There are some very simple questions that we gave them. When we tested them formally, we found that up to 15% of our patients had less than a grade 8 reading level. And so a low literacy level is grade 8 or less. So these guys had a low literacy level, and in fact we had about a 20% decline rate for this study, meaning if you were embarrassed about your literacy, you probably wouldn't want to be part of the study, would you? And the dosing instructions were incorrectly understood for brufen and methotrexate on quite a lot of occasions. Methotrexate is the drug that I get really nervous about because every 3 or 4 years, someone dies because they take the methotrexate daily rather than weekly. And the arthritis is great on the daily dose of methotrexate, but the rest of them is not so flash. So I really worry about methotrexate, and this made me quite nervous. And then, so what do we do to our patients when you want to start your fancy new drug? We give them 2 A4 size pages of paper in font 10 size. It's not great. So we then went on and looked at the information that we give them, what level of literacy is it targeted at. And I must say, I'm embarrassed to say that we found, don't worry about the details, but we found that the average reading age you're required to read our nice information is probably year 12 level, which is a problem. So we've done some things to try and improve that. So we're now using a lot more pictures. We're doing a study, for example, at Westmead, looking at point-of-care ultrasound and seeing if showing people real-time images of their inflamed joints helps them understand the disease a bit better, and therefore whether that correlates with medication adherence. So with literacy, I think, and patients, don't assume. Watch for excuses. I left my glasses at home. I didn't sleep well last night. I don't feel so well today. Use a lot of pictures. Having a support person is a good thing to do. And because I practice out west with Pablo, what happens when you use an interpreter? I don't know. The other point which I just want to highlight is medication adherence. So if you think your patients take what you prescribe when you prescribe as frequently as you think they should, I think you're wrong. It took me a while to work this out, but if you look at data across the world, medication adherence is generally poor, even with our fancy expensive drugs. And if you use your medications not appropriately, they don't work. So I will finish there. So take-home messages. Bottom line is, please, in all your PSO patients, please look for PSA because it's very treatable. And talk to your friendly rheumatologist about it. Please, in your patients, watch for poor medication adherence and low health literacy. And I think, MDT, PSA, PSO clinic is definitely the way to go. It's fun, and I certainly learn a lot from the dermatologists, and hopefully they learn a bit from me as well. So thank you very much. I'm happy to take questions.
Gary.
Yes, that's lovely.
I'm not sure the questions are coming.
No questions, all right.
Thank
That's so
you
kind. Thank you so
very,
much.
very much.
So kind. Thank you so much.
Okay, our next speaker before lunch is Dr. Jennifer Kim. She's a senior staff specialist with the Department of Tissue Pathology and Diagnostic Oncology, Institute of Clinical Pathology and Medical Research. She's a New South Wales Health Pathology at Westmead Hospital and a clinical senior lecturer in the Facility of Medicine and Health at the University of Sydney. Please welcome Dr. Jennifer Kim.
Hi everyone, my name is Jennifer Kim, and sorry, let me find my presentation because I can't seem to see it here. I can't, sorry, oh, this.
Not this one. There you see here, this one.
Oh, okay.
Forward, back, the laser, and you see your eyes.
Oh, it's up. Sorry, I was
Ignore
looking
this,
at this.
ignore
I'm
this.
sorry. Okay, so, all right. Okay. It's a pleasure to be here, and thank you for your kind invitation and for giving me the opportunity to talk about skin pathology. Okay, so I have no conflict of interest. So just a quick outline of my presentation. I'll briefly talk about inflammatory skin conditions before I move on to histology of neoplastic skin conditions, which will be the main focus of my presentation. And I'll also describe histopathology reports of skin cancers and understanding the main key points. Okay, so normal skin is composed of stratum corneum, epidermis, dermis, and subcutis. And this is how normal skin looks like under the microscope. So we have epidermis composed of predominantly squamous cells, so there are keratinocytes, and melanocytes can be found in the basal layer of epidermis. And dermis can be divided into papillary and reticular dermis, and subcutis is composed of fat. Okay, just a couple of histology photos of skin. So we have dermis showing eccrine sweat glands, and we also have pilosebaceous units for hair-bearing skin, so hair follicles with sebaceous glands. And so skin specimens can be divided into biopsy and excision specimens. So skin biopsies are usually indicated for inflammatory skin conditions and also to diagnose skin tumors. So we have a range of specimens ranging from shave biopsy, punch biopsy, and incisional biopsies depending on the size and depth of the skin specimens. And we take skin excision specimens for skin tumors, where histological margin assessment is required. So on the top right, we have an example of skin ellipse for pigmented skin lesion. It's unorientated, and we transversely section the skin so that we can examine the tissue under the microscope. So I'll move on to inflammatory skin conditions. So pathological changes can arise in epidermis, dermis, and/or subcutis. And we have 6 major tissue reaction patterns: lichenoid, spongiotic, psoriform, vesiculobullous, granulomatous, and vasculopathic. So lichenoid reaction pattern, it's characterized by basal vacuolar change, with band-like lymphocytic infiltrate in the superficial dermis. And we also have seabed bodies. So there are apoptotic keratinocytes. And clinically, so some clinical examples include lichen planus, graft versus host disease, or even connective tissue disease such as lupus. So here we have an example of erythema multiforme. We have these targetoid lesions on the left clinically, and histologically we have interface and lichenoid reaction pattern with numerous apoptotic bodies at all levels of the epidermis. And another example of TEN, or Stevens-Johnson syndrome. Here we have severe extensive necrosis and blisters, and on histology, we have detached epidermis with full thickness confluent epidermal necrosis. So spongiotic reaction pattern can be seen in cases of eczema, atopic dermatitis, or contact dermatitis. So on the right, we have an example of allergic contact dermatitis. So we have increased spaces between keratinocytes, and we also have eosinophils in the papillary dermis. Psoriasiform reaction pattern can be seen in psoriasis or lichen simplex chronicus, and it's characterized by regular epidermal hyperplasia. Vesiculobullous reaction pattern, we have blistering within or beneath epidermis or even at DEJ. So it can be intracorneal, subcorneal, intraepidermal, or suprabasilar, or subepidermal. So here is an example of pemphigus vulgaris. So we have a suprabasal blister, and on immunofluorescence, we do immunofluorescence. So on immunofluorescence, we have crisp IgG deposition in the intercellular spaces. And another example of bullous pemphigoid, in this case, this is a subepidermal blister. Usually there are numerous eosinophils. And now moving on to granulomatous reaction pattern. So common examples include granuloma annulare. It could be infections such as tuberculosis or sarcoidosis, which is a diagnosis of exclusion, or foreign body reactions such as suture granulomas. So here I'm just showing you an example of granuloma annulare. So we have annular papules clinically on the left, and there is the histology slides show necrobiotic granuloma with interstitial mucin deposition. And vasculopathic reaction pattern can be seen in cases of leukocytoclastic vasculitis or IgA vasculitis. Okay, now moving on to the main topic of my presentation. So here is the current WHO classification of skin tumors. So we have epidermal tumors, so carcinomas, BCC, SCC, Bowen's disease, Merkel cell carcinoma, and we can also have carcinoma precursors such as actinic keratosis, SEPK, and melanocytic tumors, benign lesion, nevus, dysplastic nevus, melanoma, Spitz tumor, or melanocytic tumors arising in blue nevus or congenital nevus. We also have appendigeal tumors, so tumors arising in apocrine, eccrine glands, or sebaceous tumors, or lymphoma, T-cell lymphoma, mycosis fungoides, B-cell lymphoma, and we can also have soft tissue and neural tumors. So actinic keratosis is the most common precursor of cutaneous SCC. And it's characterized by epidermal dysplasia that's not full thickness. So we can have basal, mild atypia, can have moderate atypia. But we use the term Bowenoid actinic keratosis when we observe near full thickness atypia and when it's usually focal. Bowen's disease is SCC in situ. So we see full thickness epidermal dysplasia. And it's in situ disease. There's no evidence of invasion. And now we have an SCC, which is an invasive malignancy of keratinocytes that infiltrates into dermis. And there is variable degree of differentiation and cytological features. And histological differentiation and grading is based on the degree of keratinization, nuclear atypia, and architecture. So we use 3-tier grading system as per WHO recommendation, well-differentiated, moderately differentiated, and poorly differentiated. So here we have an example of well-differentiated SCC. So we have easily recognizable squamous epithelium, there's abundant keratinization, and there's minimal pleomorphism and mitotic activity. This is another example of moderately differentiated SCC. There's less keratin formation, but there's greater architectural complexity and cytological atypia, and mitotic figures are easily identified. Poorly differentiated SCC, there's marked nuclear atypia and pleomorphism, but there's minimal keratinization, and it's difficult to establish squamous differentiation. We also have 2 histological variants divided into low risk and high risk. So low risk types include verrucous SCC, clear cell SCC, and keratoacanthoma. And high risk group includes acantholytic SCC, spindle cell, and adenosquamous carcinoma. So prognostic factors of SCC so includes depth of invasion, diameter and size of the tumor, presence of perineural invasion or lymphovascular invasion, which is associated with increased lymph node metastasis, and degree of differentiation. Okay, basal cell carcinoma, it's usually on sun-exposed skin. It's most common cancer type in Australia. It arises from the interfollicular or follicular epithelium, and it follows local aggressive course, and lymph node metastasis is rare. With BCC, we do not comment on degree of differentiation. It's rather we give a histological subtype, which are divided into low risk and high risk groups. So the low risk groups include superficial BCC, nodular BCC, or pigmented BCC, and high risk groups include infiltrating micronodular or morphic type of BCCs. So here I'm just showing you an example of superficial BCC, clinically presenting as erythematous scaly lesion, and on histology we have this superficial nest of basaloid cells attached to the epidermis. Another example of nodular BCC, we have this clinically central ulceration with rolled edges. And on histology, we have this well-circumscribed mass composed of basaloid cells. Infiltrating BCC, which is a high-risk type, you can see that there are irregular strands and elongated cores of tumor cells with conspicuous loose stroma, and there is a risk of perineural invasion. With morphic BCC, it's usually common in the head and neck region. It's a high-risk type with risk of perineural invasion. And in this case, on histology, we have compressed, so the tumor is compressed into thin strands by dense collagenous stroma with abundant mucin. So prognostic factors of BCC depends on histological type, whether it's low risk or high risk, and also circumscription of tumor margins, presence of perineural invasion, and tumor size and status of surgical margins. Merkel cell carcinoma, it's a highly aggressive primary cutaneous neuroendocrine carcinoma, and diagnosis requires microscopic evaluation as a clinical appearance is quite nonspecific and can mimic a variety of benign and malignant skin lesions. So histologically, it's a undifferentiated small blue round cell tumor with numerous mitotic figures and apoptotic bodies. Here I'm just in the middle photo is actually an immunohistochemistry for synaptophysin. So the tumor stains for neuroendocrine markers such as synaptophysin, chromogranin, and CD56, and it shows diffuse cytoplasmic staining. Just want to highlight the importance of perineural invasion in non-melanoma skin cancers. So PNI results in upstaging of the tumor to T3, and it's an indicator for adjuvant therapy. So as a pathologist, when we find perineural invasion, it's important to describe in the pathology report whether it's unifocal, so whether it's focal or multifocal, and the diameter of the involved nerve, whether it's more than 0.1 millimeter in size, anatomic location of the PNI, and whether it's within the tumor or at the invasive front of the tumor, or whether it's away from the tumor. So non-melanoma skin cancer should contain all the following information in the pathology reports: histological grading for SCC, histological subtype, tumor thickness or depth of invasion, extent of invasion, whether it's invading into dermis or subcutis, presence of perineural or lymphovascular invasion, and status of surgical margins for excision specimens. Okay, melanoma. Melanoma is a malignant melanocytic tumor arising from melanocytes in the skin and accounts for about 1% of skin cancer, but causes the majority of mortality due to skin cancer. And when you have this clinically suspicious melanocytic tumor, we actually recommend an excisional or complete biopsy with narrow margin clearance, as incomplete or partial biopsies may contribute to pathological misdiagnosis. However, it's not always possible in all cases. For example, if you have a large pigmented lesion on the face or on the foot, it's hard to take the entire biopsy. Sometimes it's useful to take multiple biopsies in the most clinically suspicious area. So this is the current histological subtype of melanoma. So we have superficial spreading melanoma, lentigo maligna melanoma, desmoplastic melanoma, can also have Spitz melanoma, acral melanoma, or melanoma arising in blue nevus or giant congenital nevus, nodular melanoma, nevoid melanoma, or melanoma not otherwise classified. So this is an example of superficial spreading melanoma, which is the most common subtype. And there's usually low sun damage. Histologically, you have this nested radial growth with prominent pagetoid spread, and BRAF V600E mutation is common. This is an example of lentigo maligna melanoma. Affects elderly patients on chronic sun-damaged skin, so it's quite common in the head and neck region, accounting for about 10% of melanomas. And there are other mutations associated, so NRAS KIT and BRAF non-V600E. Desmoplastic melanoma, again, it's on chronically sun-damaged skin. It can be pathologically very challenging, as histologically it doesn't really look like conventional melanoma. It can actually mimic scar-like tissue. So the cells become spindle, there's lots of collagen formation. On top of that, conventional melanoma markers are negative. So melan A, HMB45 are negative. The only thing that stains for are SOX10 and S100. And it can be pure or mixed. This is an example of acral lentiginous melanoma. So it arises in an acral location, palm, soles, or subungual, and KIT mutation is common. Okay, nodular melanoma is a rapidly growing tumor, accounting for about 15% of all melanomas, and it shows vertical growth phase with minimal in situ and junctional component. And on histology, we have this nodular dermal proliferation of melanocytes that's quite often ulcerated. So synoptic report of melanoma should contain all this following information: subtype, whether it's superficial spreading, lentigo maligna type, and the Breslow thickness, ulceration, presence of ulceration, dermal mitotic rate, whether there's any desmoplastic component, presence of neurotropism or lymphovascular invasion, microsatellites, tumor-infiltrating lymphocytes, regression, margins for excision specimens, and TNM staging. So breast lobe thickness is a measurement of the tumor from the top of the skin. So we measure from the granular layer to the deepest point of invasion. And it is the most single important prognostic factor for melanoma. And you can see that thick melanomas that measure more than 4 millimeter is associated with poor survival rate and poor prognosis. And we also give clock levels. So we have level 1 to 5. 1 is the in situ melanoma, it's confined to epidermis, whereas level 2, there is invasion into papillary dermis. Level 3, at the border of papillary and reticular dermis. Level 4 is when there is invasion into reticular dermis, and level 5, there is invasion into subcutis. Presence of microsatellites, it's when you see any nest of tumor cells discontinuous from the primary tumor. It can be seen clinically, or it could be microsatellites only seen under the microscope. And presence of MSI, it's actually classified as stage 3 tumor in the current AJCC staging system. It's regardless of the breast lobe thickness. So finding and looking for microsatellite is really important for patient care. And once you find the microsatellite, you need to actually assess the margins. And lymphovascular invasion, it's presence of melanoma cells within the lumen of blood vessels or lymphatics, and it's a marker for poor prognosis. Neurotropism is defined as presence of melanoma cells around nerve sheath or within nerves. So it includes both perineural and intraneural invasion. And it's associated with increased local recurrence rate. Here I'm just showing you an example of desmoplastic melanoma. So we have atypical spindle cells, and that we have these nerve fibers, and we have this melanoma cells surrounding the nerve bundles here. It's very subtle. Sometimes immunohistochemistry may be useful. And presence of desmoplastic component, it's defined as pure desmoplastic melanoma when there's more than 90% of desmoplastic type, or it can be mixed. So if you see more than, so when it's less than 10%, it's called mixed. It can be mixed with conventional or spindle cell type melanoma. And pure desmoplastic melanoma has higher local recurrence rate, but lower lymph node metastasis and improved survival when compared with patients with mixed or conventional melanomas. So poor prognostic factors for melanoma include high breast lobe thickness, positive sentinel lymph node biopsy, high mitotic rate, presence of ulceration, and presence of microsatellites, lymphovascular invasion, neurotropism, and histological subtype. So this table illustrates the current recommended melanoma-wide excision margin clearance. For melanoma in situ, the recommended surgical margin clearance is 5 millimeter, but you can see that for thick melanomas, it's up to 2 centimeter. So if melanoma breast lobe thickness is more than 4 millimeter, recommended surgical margin clearance is 2 centimeter. For melanoma measuring less than 1 millimeter, surgical margin clearance is about 1 centimeter. So sentinel lymph node is the strongest predictor of outcome for clinically localized melanoma patients. And as you can see, in the PowerPoint presentation, that the risk of lymph node metastasis increases dramatically for thick melanoma patients. So if it measures more than 4 millimeters, so stage 4 T4 melanoma cases, the risk of lymph node metastasis becomes 25 to 40%, as opposed to invasive melanoma, thin melanoma that measures less than 0.75 millimeter. The risk of lymph node metastasis is low, less than 5%. So for positive sentinel lymph node biopsy, we describe the following features: the location of the tumor, whether it's subcapsular or intraparenchymal, the presence of extranodal extension, and also the maximal single dimension of the tumor. So the picture on the right, there is this red staining that's actually SOX10 staining to identify the melanoma. So with sentinel lymph node, we have this separate sentinel lymph node protocol. We usually do HMB45 or S100 or SOX10 staining. And yeah, so it's in subcapsular location, and it's showing that red chromogen staining. So mutations in melanoma, the most common mutation is BRAF, followed by NRAS, KIT, and GNAC or GNA11. And BRAF mutations are most commonly seen in superficial spreading type of melanomas. We usually routinely perform immunohistochemistry for BRAF V600E type, and we also send the tissue for confirmatory molecular testing. Okay, so this is a current AJCC melanoma staging system. Depending on the breast lobe thickness, we have T1 to T4 tumor, and also the presence of ulceration upstages the tumor from A to B. And for regional lymph node metastasis, regardless of the breast lobe thickness, presence of MSI actually upstages the tumor to 3. So the key points, pathology reports contain important prognostic factors for, in order to guide patient management and treatment options. And we follow the reporting protocols developed by the RCPA with the Cancer Institute and Cancer Australia. And for inflammatory skin conditions, clinical pathological correlation is the key to achieve the most accurate diagnosis. So just a quick reference of my talk. And I'd like to thank my colleagues at Westmead Hospital. And thank you for your attention. Thank you.
Thank you, Dr. Kim. We'd like to present you a gift. It's a
you
bottle
so
of wine.
Okay.
The proceeds for this wine go to Ganwira Yamp, a charity.
Thank you so much.
Now it's lunchtime. See you all at 1 o'clock.